Welcome to the Women's Health Podcast. I'm Anthony Lowe, the Physio Detective.
And I'm Marika Hart, a pelvic health and musculoskeletal physio. Together we interview leading authorities, we answer questions and share our thoughts to provide the general public with the best quality information that we can find on all aspects of women's health. Please remember that the materials and the content on this podcast are intended as general information only and are for entertainment purposes.
They're not intended to be a substitute for professional medical advice, diagnosis, or treatment. Now, sit back, grab your favourite beverage, or do your own thing, and enjoy the show.
Well, hello, good morning, afternoon, wherever you're listening to this podcast. This is Marika, and I'm here with my co-host, Anthony. Hello, Anthony, how are you?
Well, thanks. It's been a while, but doing good. It's good to be back behind the microphone again, and excited to be doing the podcast today.
Yes, I feel like the last time when we got back into the swing of podcasting, we realized we'd had a break for a little while. But the reality is life just gets really busy, and we both have very busy clinical and family roles. But every now and again, we do love to grab an awesome guest and have a good chat about things that are related to women's health and fitness. So without any further ado, I would love to introduce everyone to Dr. Marie-Claire Seeley. Good afternoon, or it is afternoon your time, isn't it, Marie-Claire?
Yes, it is. Thank you, Marika and Anthony. I'm really looking forward to this discussion and really pleased that I'm able to have a chat with you about all things women's health, but particularly POTS.
So just as a bit of an intro, so I've actually met Marie-Claire a couple of times because I saw you on the EDS, I think it was an EDS Society conference, and was blown away by your presentation. I was like, oh, this is what I've been looking for in terms of POTS. So then we connected, and then you came to King Edward Hospital and presented to the doctors, and then came and presented to the physiotherapists as well. And the feedback that I actually got from the physios was, wow, that's the best in-service that we've had for years, which was just fantastic, because I think a lot of people took away really useful information about what POTS is and what are the common management strategies. And I think just really hitting home for us was just how much more prevalent it is as a problem than what most of us are aware of, but also how challenging it can be for our patients to seek the kind of help that they need. But just as a bit of an intro to Dr. Marie-Claire, so she's the founder and the CEO of the Australian POTS Foundation. And she's actually come from a clinical nurse background and now works as a research fellow at the University of Adelaide. And she brings a lot of that lived experience as well as her academic expertise to the role. And Marie-Claire has been working really, really hard to improve recognition and care and the research for POTS, which for those who've never heard this term before and think, what on earth is POTS? It's Postural, Orthostatic, Tachycardia syndrome. So it's a bit of a mouthful, which is why we call it POTS. And really, she's really pushing barriers and helping people so that we can get a more inclusive and informed healthcare system for those affected, because it's not done great in Australia, and I'm imagining it's not the best around the globe either. But anyway, that's our introduction to Dr. Marie-Claire. Anthony, do you want to jump in with the first question?
Well, I think the first question should obviously be, what exactly is POTS? So if you want to start us off with that, that'll be great.
Yeah, so unfortunately, it's a condition with a really bad name is where I would start. And as Marika said, the POTS stands for Postural Orthostatic Tachycardia syndrome. The syndrome is probably the most important part of that name, to be honest. It was named and defined really as a condition back in 1993 at the Mayo Clinic, but it's something that has been described in literature for literally hundreds of years. So there were first cases in the early medical journals in the 1800s about this post-viral, what it seemed to be then, condition. So they would see people with infections who then developed what became known, all sorts of terms, soldier's heart, asthenia kind of conditions, and it was given multiple different names. But what they described was what we still see with POTS, is that there seems to be an environmental effect or stressor in someone's life, and that might be a virus, or it might be trauma, might be a concussion, and after which they develop these symptoms that really revolve around what we call orthostatic intolerance. So people become intolerant of being upright as a hallmark feature. But POTS is a lot more than just orthostatic intolerance, and it actually, we now know, is a condition of the autonomic nervous system. So that's the nervous part of the nervous system that controls all your unconscious functions, and therefore this syndrome really has multiple dimensions to it that affect all systems of the body.
That's fantastic. It's definitely something that's out there that physiotherapists see. I'm sure fitness professionals will see them too. What are some of the common symptoms that that you see in them, in people with POTS? Because sometimes people think, oh, I'm just recovering from glandular fever, or, oh, you know, I just get a bit woozy. I've always been like that. You know, I've just got low blood pressure. What are some of the common symptoms and related conditions that are associated with POTS?
So good question, Anthony. And I think you actually highlighted a lot of things right there in that introduction that we need to think about with this. And that is, firstly, that the autonomic nervous system is, you know, historically thought of as the tension between fight and flight response and rest and digest. So we have the parasympathetic, the sympathetic, and ideally it should sit in some kind of a balance. I mean, I think we're a bit more intuitive now about the fact that the autonomic nervous system probably activates at multiple times in different ways, and it's not just a balancing act. But in essence, it should be very finely tuned to keep us comfortable in space and time and in changes to our environment. And it is likely that there is a group of people who are predisposed to autonomic nervous system disruption. And those people may have had incidents along their whole life. As you said, a lot of people will say, particularly women, who get this condition will say, oh, yes, but I always got a little bit dizzy, you know, when I stood up in the summer. I always had low blood pressure when I went to the doctors. And those things are true. And it wasn't for those people functionally disabling at that time, but they did have hints of the fact that maybe their nervous system didn't operate to the level that others do. And then it's this stressor that seems to just completely upset the whole system, that really causes the specific and escalated symptoms of what POTS is. And that is, we define it by the fact that the symptoms must be, you know, significant for the person. So they're functionally disabling for them. So they typically, the most common one is the dizziness and the pre-syncope. So standing up, headaches, feeling faint, often losing vision. All those things that I think almost anybody who has ever had a terrible infection or a fever or the flu can probably relate to, you know, when they're very unwell and they get out of bed and they get that sensation. But in these people, it's a really escalated sensation. It's persistent. It goes on for months at a time. So it's often that symptom that is the first one that's recognized. But we also see people who have other symptoms that are so dramatic that they kind of obscure that orthostatic intolerance. And so we see people, for instance, with a sudden onset of what we would refer to as functional bowel syndrome symptoms. So things like constipation, severe bloating, kind of gastroparesis type symptoms where their stomach's just not emptying the way it should. They feel full, they can't take as much intake in orally as they normally can. And if those symptoms are really dramatic, that those people tend to lose a lot of weight. And so that can be their hallmark symptom. And that's why this condition is hard to diagnose, because the difference between if somebody stood up and got really dizzy and fainted, a doctor's likely to start taking a heart rate, blood pressure, is going to look at those kind of symptoms and try and figure out what's going on. But when you have people present with sudden gastric symptoms, loss of weight, they're young, they're female, they can often go down another whole path of investigations without ever having that investigation of their orthostatic intolerance. And others will turn up with extreme fatigue, just sudden onset of fatigue, or they never got better after their glandular fever. They just, all they can describe is, I can't get out of bed, I'm exhausted. Even noise, hearing things, reading things exhausts them, having conversations exhausts them. So I would say, you know, the crux of the answer is that typically it is orthostatic intolerance, but this is a condition where we've got to look at multiple domains and have a high suspicion for anyone who's relatively young, and by young I mean under 50 years of age, who has had a sudden decline in functionality that came off the back of something like a virus or a concussion or a trauma, or pregnancy and birth is another one that we see it in. And we also need to keep our minds open to the fact that these people are likely to have a phenotype. So they are likely to be people that did have a bit of orthostatic intolerance when they're young. They're likely to have been athletic or dancers or swimmers. And we'll go into that reason a bit more late afterwards, but that is related to their connective tissue and vascular system and their propensity to develop this disorder.
Wow, there was so much in that. And my brain, I just had like a million and one things. I was just like, oh, you go here or here, here. And it's fascinating. I know Marie-Claire and I have talked a little bit before, but I have a child who's 17 who has had sudden onset extreme fatigue, sleeps 16 hours a day, et cetera, et cetera. So going down the pathway of lots and lots of different investigations, which is really, really tricky, having very siloed professionals. But we'll come back to that, because I think diagnosis and management obviously is a big thing that we're going to talk about. But can you talk a little bit about prevalence rates and sort of the gender split with POTS? So if you have any stats, that would be amazing.
Yeah, so I mean, quite honestly, we don't know the prevalence of POTS, and what we do know, and what you'll see actually quoted in literature, it really just comes from estimates from specialists in the US. But it was once thought to be quite a rare condition, and we're 100% sure that is not the case now. What we do know in terms of actual statistics is that the International Classification of Disease Code for POTS was adopted in the US in 2022. So we have data from 2022 to now. And that meant that we have a little bit of data around pre-COVID infection on people and then post-COVID infection. And there was a study where they looked at people, how many people had POTS pre-getting COVID infection and how many people developed POTS after COVID infection. And that particular study suggested that around 3.4% of all COVID infections will result in a POTS manifestation. And now you can almost double that for women, because around 90% of people that get POTS are female. And that, you know, often when I quote that statistic, people are like, well, why is that the case? And it is the case that because of that statistic, this is a condition that has been historically ignored. And I say that with good confidence because we've got good research to show that female-dominated conditions were generally linked to concepts like hysteria, and that is well documented in the research in post-viral conditions. And the fact that females dominated some of these epidemics of post-viral conditions. There was a famous outbreak of a viral illness at the Royal Free in the UK back in the 50s, and about 200 to 300 practitioners at that hospital were severely impacted with illness, most of them females because most of them were nurses. A lot of them never recovered, and that was went on to be diagnosed as an epidemic of hysteria, an epidemic of hysteria. And the reason given for that was specifically and documented at I believe it was the BMJ. We'll have to be careful about that, but it was in one of the big medical journals, was because it was a female-dominated population. That was enough evidence for them to make that assertion. And so we have this problem with the female dominance of most conditions, but of any condition that is female-dominated being put in that basket. But what we do know now, for instance, MS is a female-dominated condition, and we don't have any problems now that we can actually image the demyelination of central nerves to understand that this is an organic condition. And this is the problem with POTS, is that we still don't have a specific biomarker for this condition, and because of that, it has the, clinicians have the temptation to lump it in with those, well, maybe it's a psychosomatic condition. But what we do have is a lot of good growing evidence from research, predominantly done in the US, to be honest, but there's quite a bit coming out of Sweden as well. Now that we have proteomics and these really advanced ways of looking at proteins in the blood, looking at how the small nerve fibers are functioning, or if they're even there, we now know a lot of organic facts about POTS and what is happening in these people, and it is definitely the case that this is an organic condition. The problem is it manifests in multiple ways in different people, so we really need to understand a bit more about that. So prevalence now, there are some Chinese studies, quite a good Chinese study where they looked at a large population of young children in schools. They did the proper active standing test. They excluded people that had other illnesses. So they really tried to get a pretty normative, healthy population. And they saw that POTS was around about the 6% prevalence. And that's very, very high. If you know anything about epidemiology, that's a high figure. It is interesting because, as we alluded to, there is this connective tissue crossover issue with POTS. So people that come from a hypermobile kind of background are more likely to get this condition. And Asian populations do tend to be more hypermobile. So we don't know what the prevalence is across the board, but what I think we need to say to people out there is it's not rare. You're likely to come across it quite often in the younger female population, and you will also see men with it.
It's so interesting, and you're thinking about those stats in young children who potentially haven't then had these viral triggers and other things happening later in life. So yeah, we need some more data, don't we?
We do. We do. Yeah. We're working hard on that.
Now you've obviously dropped in the point about hypermobility and EDS, and there's that. I know you love your little oh God, what's the Venn diagram, and the crossover, and certainly clinically what we see, because I work with a lot of patients with persistent pelvic pain, and within that population, if you screen them for hypermobility, I mean, honestly, the ones that I see, it must be like 90% of them are hypermobile. But then when I ask them about the different systemic issues they have, they're having the cold hands and feet. They've got gastric issues like early satiety, so they get full really quickly, or they get constipated. And they lose, like you said, they lose a lot of weight, but then they're told you have an eating disorder, but they're like, but I can't eat because it hurts. So they'll have, and often ADHD, autism, some sort of neurodivergency as well. But we've kind of got this cluster of symptoms across so many different areas, and then all those different specialists who obviously rarely come together to put a coordinated care. And so I'm just interested in your sort of experience about the journey of women, and I'm going to say women, but I'll say people with POTS, because it does obviously affect some males. But what does that journey often look like for people, from like having these symptoms to actually getting some kind of diagnosis, to getting some kind of care?
Yeah, it's protracted, and in a lot of cases quite traumatic. And you can't really talk about POTS without talking about this Ehlers-Danlos syndrome, which you alluded to, the EDS, or the connective tissue disorders, because they seem to be such a strong crossover. And in fact, our research in our group here shows about 70% of the population that we're investigating, and that's around 1,000 patients with POTS, have some kind of hypermobility syndrome. And if you're not aware of those syndromes, there's for want of a better word, a spectrum of them, and at the one end sits the hypermobile Ehlers-Danlos syndrome, and then the others are broadly termed hypermobile syndromes. So, there's a really strong crossover with that condition, and we're learning more and more and more about Ehlers-Danlos syndrome because of the fantastic work really that's been driven out of the UK groups in research. these people have really complex crossover of multi-system issues, and it was really the revelation of the connective tissue side of this condition that helped in my own particular journey. I was diagnosed with POTS. Well, I wasn't diagnosed for many, many years, but I developed POTS at the age of 24 after a pretty nasty virus when I was overseas. But it was actually my children. One of my eldest one was born and had multiple dislocations before she was 2, had all these weird things going on, you know, the things that make you start worrying as a mother that some doctor's going to turn around and start talking to you about, you know, have you got Munchausen's by proxy, and are you a hypochondriac and enforcing this on your child? They're all real things. I mean, her elbows repeatedly dislocated. She had to have a coccyx removed at the age of 13 because it was so hypermobile that it flipped back on itself when she sat down. I mean, just weird and extraordinary and, you know, issues, nothing life-threatening, but things that made life very difficult for her. She had a lot of functional gut issues from the day she was born. So she was fully breastfed, was unable to basically pass poo. So she was so constipated as a baby that we had to have intervention for her. She was on all sorts of things, you know, as a young child for that. And I just kept thinking in my mind, this is not normal. It is not normal to have a fully breastfed baby that, you know, is so severely constipated. Then she started vomiting. She had, you know, a lot of reflux, obviously. And those conditions extended on into her young adulthood and further. And subsequently, she developed everything that you deal with, Marika. In fact, I've got 3 daughters, and there's that range of those issues of pelvic pains, of severe endometriosis, and I'm saying all of this just to show that these are the women that develop these systemic connective tissue issues through their lifetime, and they tend to, you know, progress as they get older. Obviously, your connective tissue becomes less tensile or more, you know, you have more issues as the connective tissue kind of degrades, I guess. And so you get a lot of pelvic issues, you get a lot of gastric issues, and you get a lot of joint issues. And our family, I think, has really kept the whole private medical system in play through our medical insurance. I've lost count of the amount of orthopedic surgeries that my 4 children have had to have between them.
You hit that Medicare. You hit that Medicare limit early,
we
right?
hit it every year from the day. And
yeah.
And they're all legitimate issues. You know, I wasn't throwing them downstairs and doing anything terrible to them, but that's, you know, they just had so many problems. My 6'4" son stood up last year from sitting on the ground and dislocated his knee and ruptured his meniscus. So, and he's a very fit rower, you know. So these are issues that happen to people in everyday life, but they get very concentrated in this population. And you can imagine, you know, they're the things that get attention. When you dislocate your knee, you get attention, but they also have all these chronic issues that are pain related, that are appetite related. They often have terrible sleep issues. So all sorts of sleep disorder issues. And those things are really troubling. They can affect mental health, but they're not things that a GP can fix with a 15-minute appointment. So these people typically, along their diagnostic journey, learn that there's a lot of things that they just can't tell a doctor because the doctor's going to dismiss them or tell them there's nothing to do about it. You just need to get on with things. And they become more and more insular and more traumatized by their encounters with the medical system. And usually by the time we do get to diagnose them with POTS, there's a lot of distrust of the medical system. There's a lot of trauma, and there is a lot of relief when you can sit down and explain to a person how their connective tissue interplays with their autonomic nervous system, which all those small nerve fibers are sitting in connective tissue, trying to keep this body moderated with heat, with sweat, with blood pressure, with heart rate. And there is a lot of relief when they are finally given that key to understand that this is not them going mad, that everything actually interlocks and interplays. It's not their fault. and that there are ways in which we can help to at least support some of those symptoms and avoid some of the triggers for some of the worst things that they have to deal with.
Yeah, it's such a difficult journey for people sometimes, in terms of, like you said, the variety of symptoms, and being able to speak to somebody like yourself or another professional who can explain all of those things. And when you explain the wide variety of symptoms that you can have, and it makes me think about post-COVID type syndrome, the EDS. How do you differentially diagnose, or like, is POTS a description of symptoms that you get because you have connective tissue disorders, or is it just, okay, do you know what I mean? Like, it's the autonomic nervous system that's affected, but is that because of these other things? Is it interplaying with each other? When is it like the mitochondrial issue in, say, post-COVID for the fatigue versus the POTS side of things and something else that's affecting the autonomic nervous system? Do you have anything on that?
Great question, Anthony. And there's we could do 3 podcasts on that question, really, I think. So let's just start with autonomic nervous system disorders. Their umbrella term is actually dysautonomia. That is not a diagnosis. It's just a term for many conditions. And there are, under that umbrella, conditions that are familial, that people are genetically born with, and they tend to be very, very rare and sometimes life-threatening. So there are a few autonomic conditions that essentially the autonomic nervous system doesn't work from day one, and it gets worse, and you will rarely come across those, but they do exist, and they have a definitive diagnostic criteria that relates to antibodies and also to their genes. The most common autonomic disorder that we see is actually POTS, and probably the other one that goes with that is orthostatic hypotension, which is technically an autonomic disorder as well. Those disorders can be primary or secondary, and there's no clear definition on them, because often we can't find out what is driving conditions, but we're suspicious that this person might have an autoimmune disease. But there are very clear instances in which POTS becomes a secondary condition that results from a primary condition. A good example of that is diabetes. So diabetic neuropathy results in autonomic dysfunction because it's the neuropathy of the autonomic nervous system. And so people with diabetes that is uncontrolled, they will damage those small nerves that controls their blood pressure, their heart rate, their sweat function. They'll develop gastroparesis and all those autonomic kind of failure symptoms. They might end up with issues with their bladder as well. And that's clearly a secondary autonomic failure. In that, we could probably go diagnose some of those people with POTS, because if your autonomic system fails, you will probably develop POTS. POTS does have a specific diagnostic criteria. It's not a cluster of symptoms criteria. It's actually a blood pressure, heart rate criteria that is diagnosed on a specific either stand test for 10 minutes or a tilt table test. But it must have accompanying with it a range of symptoms that are suggestive of POTS. But there is also primary POTS, and we need to really make that clear that there are people that walk into our clinic that have no connective tissue issues, that have no other autoimmune condition that we can identify, and they have just developed POTS. I would say that they're in the lesser group, and the majority really sits in this connective tissue space. And what is POTS secondary to the connective tissue disorder, or how does that work? And that's a really good question, and one that a lot of researchers and clinicians will argue over for a long time, I think, because we actually don't know what causes the connective tissue diseases. Of course, everybody thinks, because it comes from the Ehlers-Danlos group, that this is genetic, but we have no gene for the hypermobile Ehlers-Danlos syndrome identified, despite a lot of effort in doing so. And there is some evidence that connective tissue actually modifies and degrades in environmental stresses. And for instance, lots of inflammation can change the way the connective tissue interacts. And it is entirely possible that in some ways there could be some environmental factors that cause connective tissue to change and develop these kind of features. And we have a bit of evidence for that, but not enough to say exactly that is it. And in terms of your long COVID, so, we did some prospective research, one of the first studies done in Australia and the only one on autonomic function in this group that was published at the time. And we showed 80% of people that just turned up with long COVID. So this was this is back in 2021. Most people had not heard of POTS. The study just enrolled people that had long COVID. So they had developed a COVID infection, and within 3 months later, they were still suffering from symptoms that were unexplained by any other condition. We tested them quite thoroughly, and 80% of them had POTS. And there was a lot of international studies that also went on that confirmed this, that around 80% of anybody with long COVID will have an autonomic disorder, be it POTS or be it orthostatic hypotension or another defined autonomic condition, which is called initial orthostatic hypotension, which is quite hard to pick up. It takes specialized equipment, but it is slightly different. Now, those long COVID people, are they the same as the Epstein-Barr virus or the glandular fever people that develop POTS or ME/CFS, chronic fatigue syndrome? And the answer is probably not, because it's a different virus, but it's the same kind of mechanism. It's not the virus causing these issues, it's the immune response to environmental triggers that's causing it. Do they all have mitochondrial dysfunction? Probably not, but some might. And this is where treating this condition is a lot about teasing out what is the individual symptoms and how do we deal with them. What I will say is that we have seen in our clinic, more than several people who have turned up with, years-long diagnosis of ME/CFS, chronic fatigue syndrome, had never been tested for POTS. When we tested them for POTS and treated their orthostatic intolerance, they improved, and a lot of now it doesn't go away, the condition is quite chronic, but they were able to increase their functionality and their quality of life. And we have one particular girl who actually, does a bit of media for us and talks to people about her story. She had to exit from school, was unable to finish school or finish university, and spent 6 years being told that this is the rest of your life. And it wasn't until her POTS was diagnosed and she was treated for her orthostatic intolerance that she was able to start getting functionality back and was eventually able to return to university. And I think I keep her in my mind because, we don't have many options for these people, whether it's ME/CFS, fibromyalgia, or long COVID, apart from let's get their blood flow going again. And when we can make sure that they get blood to their head, that they're able to stand upright, we can start to improve functionality in them. And it's really important that we diagnose this condition and that we treat it appropriately.
Absolutely. It's, as you were talking, I was thinking about the different types of people that I've seen with all the different things, but with the POTS symptoms or diagnosis. And this is just my biased sample, tends to be late high school or university aged women, and usually post-viral, right? That's the most common thing that I've seen. And obviously lots of different people out there will have lots of different reasons why. Often the headaches, the fatigue, the difficulty transitioning from different positions, lying to standing, standing to sitting, floor to stand, stuff like that. Especially if they like Pilates and yoga, and then suddenly they can't do the inversions and the change in positions. These are amongst the most common presentations I see. And for the clinical, and for the people listening with POTS, what are some of the most common management things that are the most helpful because they often do have EDS, or they are post-COVID, or they do have some of the other conditions that we talked about earlier. What's some of the most common, I'm a dumb physio, let me help my patient who's got these things as well, right? Because usually they come to see me for something painful, like neck, headache, back, whatever. But it's like, you've got this as well. What should I do?
Right. So the first place I would start with a physio or an exercise physiologist who has not dealt with this condition before, or a little unsure with the condition, is start with deconditioning is almost never the cause of this condition. And we actually used to start the other way around, because it was always, and I'll give you some background on that for people that aren't familiar, almost all autonomic medicine science was undertaken in the aeronautical space world, because that's why we became interested in the autonomic nervous system. NASA was sending people to space. They were coming back deconditioned, unable to stand. They needed to understand what happened to them in that physiology. Why was that happening? Hence, we have the term the NASA test, where we actually test autonomic function in people. And it was reasonable then to consider, okay, these astronauts have been in space, they're not in gravity, they're deconditioned because they're not having to fight gravity or exercise in gravity. Therefore, their heart shrinks, their blood doesn't flow so well, and we need to recondition them when they come back to Earth. And so we started with that premise, back in the 80s, that maybe all these people developing POTS have got POTS because they got deconditioned from their 2 weeks in bed with their virus, and they just haven't, basically got their function back because of that. And I mean, that's a relatively, logical theory until you meet the people who get this condition. And that's what I would really say. You need to listen to the story of the individual in front of you, because we get many elite athletes walking in our clinic. I mean, one of the world's greatest ever swimmers, in fact, she probably is the world's best and greatest swimmer ever, Katie Ledecky, has POTS. And she still struggles with POTS on a day-to-day. She has to manage it day-to-day. And I don't know if you just watched the World Swimming Championships, but she got beaten by an Australian the other night. But their US team had been hit down with the gastric virus. And I was thinking about Katie Ledecky. I thought, well, she would be the worst person to get that, because her POTS is, her blood volume is her big issue. And as an athlete, trying to maintain that in such a high competitive level with a gastric virus is not going to do it that well. Suffice to say, you can be the world's best athlete and still have POTS, and it's not a deconditioning area. So don't start with you are deconditioned, because you won't get very far with these patients if you do. And the reason for that is that they're very prone to triggers. So it's a very fluctuating condition, and a lot of people, I can walk 30 kilometres if I want to at the right time when I'm trained for it, but I might not be able to walk one in the middle of summer. And that is exactly the point. They're very affected by the environment. So heat is a big trigger. The blood pressure just does not get back to the head. If you try and go and exercise these people without good cerebral perfusion, you're going to cause them significant fatigue episodes, probably pain, headache, migraine, and so on. So you need to start on a basis of, let's find what their level is in each individual right now. And the best way to do that now, we've got a lot of access to wearables, so we can have a good look at people's responses to exercise in the days post working with them. And we need to really use those tools. And if your audience is familiar with heart rate variability, that's one of the best tools to use in terms of biofeedback with these people. So I would start with, first, are they maximised on their blood plasma volume being lifted up? Because typically 30% of POTS patients, the majority of POTS patients have 30% less blood volume than normal people, and that probably relates to the autonomic control of blood volume through the kidneys. So if that's off a bit, then you get people that actually have less blood volume and it's not getting around their body properly. So we need to maximise that through not just free water. If we just give them water, they're just going to pee more out. So we need to make sure they're really using a lot of sodium and fluid to maintain that fluid into their blood volume. So typically, we say 2 heaped teaspoons of salt a day. And if anybody knows much about salt loading, that's a truckload of salt. So they usually need a little bit of hydration salts. Some of these low sugar hydration drinks are quite good to get the volume in, plus the salt to make sure that their blood volume gets up. Then we need to think about the blood returning to the brain, and the best way to do that is through ankle to waist compression. And then we need to start looking at what's their exercise tolerance. Okay, if we've got them fully hydrated, we've got them fully compressed, what can they do without triggering their symptoms? And Marika really alluded to those issues with Pilates and yoga, which are considered kind of recumbent exercises that should be safe, but a lot of them use inversion positions, which are no good for somebody who's struggling to get blood back up to their head. So we've got to think about positionally starting them on the ground with their head in a static position. So things like exercises laying on the floor or doing recumbent cycling is a good one to do. And then we stagger up from there. And then the other thing I would say is don't expect fast or a linear progression. Typically, these people go up and down, and it's very disparaging for them when they kind of are making some gains and then they fail again. And part of your job is to be the coach there, tell them that it's okay, they'll come out of that. We just need to take a break and start again, those kind of things. And also, it's very incremental progression. And so, you can be talking about months on a program, whereas if we really were talking about a deconditioned patient, you'd be thinking, especially if they're 20-something, you'd be thinking you could get them up in a couple of weeks. That's not going to happen with POTS. You really got to take the long-term view with these people. And probably the last thing I'd say is the connective tissue issue is a big one. And you really want to do a full assessment on, things like cranial cervical stability, working on core muscle development to really make sure that they're able to hold their spine and their neck up correctly, doing a lot of strengthening around that, because that's where a lot of your blood flow issues can congest. So we want to make sure that these people have some core stability to protect those hypermobile joints and get some good muscle mass onto them, because they're very dependent on their skeletal muscle pump to actually pump fluid around their body.
Yeah.
That was such a good summary.
It was a very long one. I was like, I'm going on for a long time.
I had a quick question. Just because my brain works funny, okay, Marie-Claire? Do people actually just pop a bag of saline up to rehydrate? Like is this a thing? Yeah. I've got a patient who when he was going through cancer treatment, he got a private nurse, and he would come and he would get IV vitamins and saline and a whole bunch of stuff. Like, is that a thing? People just pop.
It is a thing, and you've wandered unknowingly, Anthony, into a very controversial area of POTS management.
Oops.
Oops. And it makes sense, right? These people have low blood volume. The higher you can lift their blood volume, the better that they function. And really a bag of saline is a good diagnostic test for a lot of POTS patients, right? You get someone in who's pretty orthostatically intolerant, low blood pressure, typically. You give them a bag of saline, their heart rate goes down, they feel better, and you think, oh, wow, this is a great solution. What is the problem with that then? Obviously, the problem is it doesn't last. And so within 24 hours, they're usually, back to where they were. And repeated use of saline actually has the opposite effect on the kidneys. So the kidneys start to think, we've got a lot of fluid running through us. We don't need to hang on to too much sodium and fluid here. And they actually start to diurese, which is a hard thing to explain to patients. And we have that same problem, actually. Patients often come in already over drinking. And just to be really clear, nobody's ever done any study that shows us what is the normal amount of fluid anyone's supposed to drink. We really don't know that. We assume that more is better, but more is not always better. And in fact, free water without sodium in it washes out your kidneys. And what it does is teach your kidneys to actually offload more sodium and more water. And you can induce in someone what we call primary insipidus or polyuria. So you basically cause this person to diurese and get rid of their fluid volume. And a lot of POTS patients come in with that because they're always thirsty, they're always dizzy, and they're drinking 3 or 4 or 5 litres of water. And
I have to say, working in the urogynae department, more is not necessarily better. We had a patient the other week. Actually, no, she was a pelvic pain patient who was drinking a litre every hour at work. And I clarified this, and so she's consuming more than 8 litres a day of fluid.
Yes.
And funnily enough, had urinary urgency, but
and primary
frequency.
area. I mean, she's given herself diabetes insipidus essentially. If you looked at the concentration, urine concentration, should have none. But it's not. I mean, the thing is, we often also go to, oh, well, that's a psychiatric problem. That's what they used to think. People that drank too much, psychiatric issue, and maybe it is in some cases. But with these people, it's often the body knows it's missing out on something. You feel, I mean, people get dry eye and dry mouth, right? Because your secretory function's controlled by your autonomic nervous system. Some people actually have the small nerve fibers are completely gone or disrupted, and they have what they call Sjogren's disease. So they have this constant sense that they are dry, their skin's dry, their eyes dry, they drink and drink, and then the body needs more and more because it's peeing more and more. So it's important to know that too much fluid is a problem, and when we hydrate people, we want them going around the 2 to 3 litres. We think that that's probably moderate, and it's still a lot to do. For 3 litres is a lot in a day. 8 litres is obscene, but they must have it with a large dose of sodium. And this is one of the big problems in re-educating people with POTS and practitioners around POTS, is they get very nervous about the salt. We've spent billions on educating the whole of the world on why salt is bad. But I often ask clinicians, well, why is salt bad? And they're like, oh, because it, gives you stroke, it gives you heart disease. I'm like, well, does it? What does salt do? Salt increases your blood pressure. High blood pressure causes damage to arteries and can lead to heart disease and salt. But these people do not have high blood pressure. These are young, hyperflexible people with vessels that just dilate. They often have very somewhat stretchy skin, and so they've got saggy. I often tell my patients, this is like your garden hose that's been sitting in the sun for 4 hours. The hose is just saggy. It's got no tensile strength to it. You're trying to get some pressure to the end of your garden with your hose. You've got low pressure already in the hose because your blood volume's down, and the hose is saggy and it's got no tensile strength. And so you get no pressure out the end. So you get no pressure or blood flow into your brain when you're standing upright. So we really do need to lift their blood volume, and salt is not an issue for these young people with autonomic dysfunction. It possibly is something that we really need to consider as they move into the menopausal phase and get older, and autonomic control is an issue in menopause for most women anyway, and that's where primary hypertension can become a problem, and that's where we really need to be a bit more careful. But when we're talking about the younger population, we do want volume. And just the other thing on the IV fluids, so number one, it's not practical, it's expensive, it's invasive, and it can wash out their kidneys. But then also, if you put in the problem of the connective tissue issue, what you will find, a lot of these people are really hard to cannulate. So typically they've got low blood volume and they've got vessels that are hard to cannulate because they've got the connective tissue issue. And so then you start very, very quickly discovering that to get any access to them, you need to start putting in invasive lines. We see people that start to have PICC lines put in and ports, and invariably they are going to get infected. They're going to move because of the connective tissue. It's a high risk thing to do, and it's not advisable or tenable in the long run. What we will say is that rescue fluids are really beneficial in POTS. And if you're a GP clinician, I would say if you're looking after somebody long-term with POTS and they have a dramatic POTS flare, let's say you've got a 17-year-old at school, year 12, she's unfortunately come down with COVID, because everybody's got COVID in her class. She's going to really struggle to get back up and back to school, whereas her classmates are probably, going to recover a lot quicker. A bag of fluid may be something that can get her up and and that is the case in which she needs to recondition. She will need to, put some effort into actually getting her body back and upright and able to tolerate, a couple of hours at school. And those rescue fluids are quite helpful. And the same if someone has gastro, and they're losing 2 litres and they've got POTS, someone who's relatively healthy will just be able to drink and get over that. A POTS patient may not, and they may need a rescue bag of fluids to bring them back.
So in other words, use your brain and clinically reason yourself through this. Just like the salt thing. Like the salt thing, it's just like, well, duh, it raises the blood pressure. Like these people have low blood pressure, but yeah, like you said, billions are being spent. I should be really
clear with that, Anthony. It's if you take a POTS patient's blood pressure when they're standing up, it's likely to be high. That's the diagnostic criteria, in fact, is on standing, their heart rate goes high and their blood pressure does not drop. That is the clear diagnostic criteria. So it is not unusual to see a high blood pressure in a POTS patient standing. And in fact, it's more likely what you will see. The reason for that is because they have lost their blood volume to their brain. They get a lot of adrenaline out. We call it hyperadrenergic response. They do get some central constriction, not in their peripheries, but centrally. So they get a higher blood pressure and their heart starts to race. But if you get a POTS patient and lay them down or take their blood pressure early in the morning, for sure you're going to find these kind of 90 systolic blood pressures, and that's probably their normal blood pressure. So I just want to clarify that high blood pressure can be present, but it's purely orthostatically induced. And if you give that high blood pressure person a litre of fluid, probably their blood pressure will drop, because you will cut off the need for the adrenaline and the adrenaline will settle down.
So if I was just to layman's it a bit, just to make sure I understood it, when you go to stand up and they take the blood pressure, the volume of blood has escaped your head, which has got a lot of blood in it. And so then it will appear like blood pressure and your heart will race and your adrenals will scream because of that change out of the brain. Is that what?
Yeah, so most people do not need adrenaline to be released from their adrenal glands when they stand up, because they have a good autonomic nervous system. So these people standing up is like, you having a fright of your life. The same thing, you get a pounding heart, a release of adrenaline that constricts. So adrenaline's there to try and maintain that pressure. And what they saw in the very early studies in America, when they looked at what happened with vessels with these people on tilt, was that their leg vessels didn't constrict at all. And we suspect these are these Ehlers-Danlos people. The peripheries, the vessels aren't constricting in the legs. But because of all the adrenaline that's rushing around the body, the central vessels are constricting. So the ones in the brain and the ones in the heart. And so these people often get chest pain and migraine with that adrenaline rush. They might even get a really flushed red face. That's the adrenaline coming to the surface. And it looks and feels like a panic attack. But it is a panic attack that's initiated from not enough blood getting to the brain when this person has stood up. And that's why you get these elevated blood pressures. As soon as you lay that person down, their heart rate will go down, their blood pressure will go down. And that's how we can tell it's not a panic attack, because I can tell you what doesn't happen in a panic attack is that your blood pressure and your heart rate doesn't settle down when you lay down. You just feel like you can't breathe and you're going to die because you're having a panic attack. But this is definitely orthostatically initiated responses.
So to summarize the management stuff, the hydration, loss of blood volume, so making sure that they hydrate, but the hydration with salt. You know, making sure that that's there, because without the salt, you can actually teach your kidneys to strip you of more sodium, which would be unhelpful. The physical support, so ankle to waist compression to help return the blood to the brain and the heart, I'm guessing. And with the exercise side of things, you know, recumbent cycles, supported positions, avoid inversion, and, you know, taking care of the tissue. I think you described it as the tissue disorders. So the tissue issues, right? Which means that because they've got more flexibility, making sure they have adequate support for their joints, what we still call core stability. But really, it's control of your joints is what we're after. So starting there, so it's going to look like gentle exercise, but also, you know, trying to build that up so that we get some of that muscular return, blood flow return as well, with the muscular resistance and the long time frame. Take a long view for this one, because it's certainly not going to be a deconditioned person like a post-stroke. You know, within 3 to 6 weeks, you're going to see improvements in their aerobic capacity or whatever. It's going to be months, and to be patient, and the roller coaster ride will be there. But I'm going to guess consistency will show a long-term improvement over time, but day to day, it may feel like a failure and you did something wrong and you've done nothing different. And then,
Absolutely.
Yeah. Is that fair?
I think all of that's great, and you should write up a little cheat sheet on that for your audience. But I think one of the things to know as a clinician is your biggest role in managing POTS is really as a health coach. It is a lot about empowering the individual and encouraging the individual to understand and, you know, to learn. And these are young people. I'm particularly talking about the adolescent, young adult age, who are not, you know, once you're older, you've been through a lot more, you've maybe had children, you know what life is really about in terms of medical conditions, and you know, you own a lot more of your crap basically as you get older. But when you're young, you know, you're not geared to expect this. You're not geared to expect that your whole life is about to stand still while your friends and peers are off, you know, on the most exciting time of their life, developing their careers and so on. So there's a lot of complex interplay mentally for these people, and they often have very, very limited access to support. So we don't have the equivalent of cancer societies for young people with this condition, even though this condition has been shown to have worse quality of life than cancer, than heart disease, than kidney disease, and yet they're often on their own. So the clinicians really are playing a mental health role there in really helping this person to understand that most of the power lays within them in terms of who, you know, how are they going to improve, but not to beat themselves up, that it's normal for people with this condition to have flares, to have crashes, and that we're going to learn how those flares and crashes happen with time, with inspection, looking at what are triggering things, and that you're there really to encourage them along the way. I think that's really an important part of the clinician's therapy for these people.
The resilience training, right?
Yeah, it is. Don't use that word, but yes, it is 100%. And it's hard in this population. Marika alluded to this at the start, and we haven't talked about it because it's another whole podcast, but there is a high neurodiversity amongst the connective tissue population, very high. So autism spectrum disorder and ADHD. So there is a tendency, as we know, amongst those conditions to get fixated on things. There's a lot of hypersensitivity, And so we've got to really balance that in that person, and that's part of the clinician's job, is to know, you know, to find out whether those kind of features are there and what the risk is for that individual to become too focused on symptoms, and balance that issue as well. Because, you know, we want them to understand their triggers, but we don't want them to develop anxiety disorders around every symptom that they're feeling. So resilience training is kind of part of that.
Yeah. It's I'm just thinking about quite a lot of the patients that I work with, and in the public system, we obviously have quite a limited amount of appointments. So for example, they're often coming to see me not for POTS, it's for, you know, pelvic pain or incontinence or, you know, other bladder issues. So that kind of comes up as being a bit of a side note. And I have to say nearly all the patients have never heard of it before I've raised it. So it's kind of really challenging in that situation, because I kind of don't want to go, oh, have you got about this thing, and dumping that on them and then saying, well, good luck with that, because I'm not going to be able to support you long term. So I usually try and help them on their way. And I do want to talk about the medication side of things, and how to build a bit of an MDT around, because these patients really do need an MDT, and they do need longer sort of term management. So I do want to come to that. But just before we do, just going back to the diagnostic side of things, Marie-Claire, if you could just quickly just describe the Nasaline test, just for people who've never heard of it, or if you can, if it's probably on your website, you can just direct people there. And the other thing was, I know we talked about the questionnaire, I think is it the MELMA? I think it's the MELMA, isn't it? If you could just let people know where to find those.
Sure. If you go to potsfoundation.org.au, our website's actually getting an overhaul at the moment, and the new one's going to be out in 4 weeks, but everything's still there at the moment. You will find that we have a POTS for Practitioners page. On there, you will find a few diagnostic resources. On our new website, we'll have a whole cheat sheet on the active stand test. So the Nasaline test and the active stand test are almost interchangeable names, but we refer to it as the active stand test. So that is essentially a test where you look at somebody's heart rate and blood pressure when they're well rested, laying supine. Then you stand them up, and without letting them move their legs or fidget, so we don't want any skeletal muscle kind of pumping, we just get them to stand, and for every minute you take their blood pressure and heart rate. And we look at the heart rate response to that 10-minute stand. And if their heart rate goes up by 30 beats or more from when they were laying flat down, then we consider that a positive diagnostic test for POTS, if that is also accompanied by orthostatic intolerance symptoms. So they've been telling you that they feel dizzy when they stand up and so on. And so the instructions and the nuances of that test, you'll find some information on our website. But there also now is a fantastic little survey, and this was brought out by the Swedish group. There's a fantastic researcher, cardiologist, Arta Fedorowski, who does a lot in POTS, and they developed a validated tool. We call it the Malmo. Malmo is the Swedish city. POTS survey, MAPS is the other name they call it. You'll find that on our website, and it's just 12 simple questions about a broad range of symptoms, and it has a cutoff score in it, which is helpful. I just need to caveat that with it was tested in a POTS population compared to healthy controls. And if you're a clinician that's seeing a lot of people with complex illnesses, it's not, the cutoff score won't necessarily discriminate for you, the person with POTS, from the person with pelvic pain and fibromyalgia, for instance, because they often have, you know, a lot of symptoms that are around there. But what it does help you do is see what are the key areas that this person is really struggling with. So it looks at things like gastrointestinal fatigue, headache, those kind of things, and you can really identify where this person is having the most amount of problems. So those tools are readily available. We're also doing an active standing test video, which is going to be up on our new website, and it's specifically made to instruct allied health and GPs on how to run that test. And we're RACGP accredited, and we run webinars. We've got one coming up in September for any APRA registered allied health that would like to join that. So if you go onto our website, you can sign up on our newsletter and you'll get information about all these things as they're coming out.
That's fantastic. I feel like we could talk to you forever, but I just wanted, we will wrap up in a sec, but I just wanted to talk a little bit about the MDT side of things. Because, you know, you've talked about all these different systems that are potentially involved with patients. Some patients will end up seeing a cardiologist for Holters, for assessment of blood pressure changes, and etc. What are other and the medication side of things? So I know some cardiologists will prescribe medications. I just wanted to ask you about what other people might be in the MDT for POTS, and what would be the first? I mean, I guess the GP would be the first initial place to go, but not all GPs know a lot about POTS. Do they prescribe medication as well, or does that normally come through the cardiologists, or what does that look like?
So I'll try and tackle that one bit by one bit. So we would prefer people go see their GPs. As you said, not all GPs know about this, but I will say GP land is far more au fait with it now than 3 years ago, and we're increasingly seeing clinics that are treating this condition very well, and strangely in the pelvic pain space. So the 22 endometriosis clinics that opened up around Australia, not all of them by any stretch, but a few of those have very quickly recognised that they're seeing a lot of people with POTS, and so have started to really upskill their own clinics in how to manage this using an MDT model, so using practice nurses and so on to really help in the assessment of that. As you alluded to, some GPs will just send people off to cardiologists. A lot of cardiologists know what this condition is, but don't necessarily recognise it straight off or think it's something that's rare. And unfortunately, Holter monitors are not assessed to look at POTS. Now, if somebody is familiar with POTS, so our clinic's a cardiology clinic, and all of us can look at a Holter monitor and go, yep, that person has POTS. Is a very, you know, the picture is quite clear if you know what you're looking for. The problem is a lot of people get Holter monitors. They're just reported back with a normal to the GP, and the GP doesn't know, you know, how much tachycardia they had. As long as they didn't have an arrhythmia, they're often reported as normal, and that's not what we're looking for in POTS. We're looking for tachycardia and autonomic nervous system kind of dysfunction in that. So generally, we would prefer that everybody went through GPs, because that's where they're going to get the most support, and it's the GP that can then organise the chronic healthcare plan. And that's about to change. The MBS item numbers are about to change for that. I guess your cohort might be, your peers might be all over that, but we used to have the team care arrangement and the chronic healthcare plan, and it's been merged into kind of one system now. And the benefit of that is that these people do need multidisciplinary care. That it's very rare for them not to need some input from, I would say all of them should have either a physio who's au fait with POTS or an exercise physiologist in their care team, because they're the ones that can really help them with that, the movement, but also the health coaching. They're the ones that understand a lot of that and the physiology of orthostatic intolerance. A lot of them need dietitians, and particularly if they have the functional gastric symptoms, you are not going to get a POTS patient better or improved if they're not able to tolerate fluid volume and they're losing weight. And so dietetics is really important to engage early with those people. I'd be very selective in dietetics. Not all dietitians understand that this is not an eating disorder, but it's a functional gut issue. And so we need to be very careful that is clearly detailed and that we integrate them into care with good dietitians. And I would say that there is an emergence now of online kind of telehealth centres that are multi-D. And there's one actually in Perth, Marika, where you are. So they've just launched, and they have a swathe of different specialties. So dietitians, physios, they have a cardiac geneticist, they have a genetic counsellor, they have a nurse practitioner who's able to prescribe medications. Does it
start with a B?
Yes.
Oh,
right.
We're going there next week.
Oh, there you go. So they're new in this space, but what they recognised was, from their personal experience, was that there was a real need for this telehealth services in this space. And I think we're going to see a lot more of that opening up around Australia in the years to come. Medications. So there are two things that we really target first off with POTS. One is blood volume and one is heart rate. If you go targeting heart rate and lowering that first without increasing blood volume, you're probably going to make this person worse, because their heart rate is their compensation for lack of blood volume. And so if you just drop that heart rate, they're either going to start fainting or they're just going to feel nauseous and fatigued and so on. So we usually target blood volume first with the drinking, with the salt, and then if they still need support, there's a medication that is used off script called Midodrine. It's a vasopressor, so it stimulates those little nerves to press those vessels in the peripheries that aren't working. It works wonderfully. Unfortunately, it's expensive. It's about $120 a month. And it's very short acting, so you have to take it every 3 hours, but it works really well for a lot of POTS patients. GPs can prescribe it. The question is, will the GP that you're seeing prescribe it? And the answer is probably not, unless they're experienced in the POTS space. But they 100% can prescribe it. They need to have confidence in it. So often what they will do is send the patient off to a cardiologist first, get the cardiologist to, if the cardiologist says, yes, this is what they should have, then they'll take up the prescribing afterwards. And what often is the case in POTS is you often have to use two in conjunction together. So this is assuming lifestyle changes have not improved the person to the point that they're functional again. We would add on medications, so it would be Midodrine, and often we use ivabradine. A lot of GPs will use propranolol because it's a beta blocker that they're used to. They know it's short-acting-ish and they know it's relatively safe. The problem with beta blockers is that they drop your blood pressure, which is the underlying issue in this population. It can be beneficial in some people. We don't use it first off typically, but we do find the occasional person it works in. And you will find a lot of POTS patients on propranolol because they complain consistently of headaches, and that's often the first thing that they get given for their migraines, which are mostly orthostatically occurring or because of lack of blood volume. But the other preferable drug is called ivabradine, and it is a specific drug that only affects the rate of the heart, doesn't affect your blood pressure. It's a really good little medication. Again, it's off script. It's about $40 a month. And it can be prescribed by GPs, but again, they would have to be familiar with it and confident for them to want to do that. What I should say on both those medications is that they're not tested in pregnancy, so they're not suitable for Midodrine. Some specialists leave their pregnant ladies on, but it's a class B drug, but ivabradine cannot be taken in pregnancy.
Wow, so much good information. So much good information. Thank you very much for everything. We have to wind it up. It has to come to an end at some point. I'd love to do 4-hour podcasts just talking about a topic. But all right, let me see if we can go over what we've covered so far. So we talked about POTS and what POTS is and how it's an autonomic nervous system disorder. 3 to 4%, or is it 3.4% post-COVID? But 90% of POTS sufferers are female, and we talked about the difficulties and historically and currently of having predominantly female presentation, which is very annoying and frustrating. I'm frustrated. I was frustrated. That's why I was muted. Anyway, common symptoms include dizziness on standing, fatigue, gastrointestinal issues, headaches. We talked about the change in the blood pressure and the heart rate and the nerves. We talked about the comorbidities. We talked about how a sensitivity to things like heat and the environment and what's going on can affect their presentation. You know, you mentioned you could do 30 kilometers if you were trained for that, but on a hot summer's day, you'll be lucky to get through one. It's not about a fitness problem. It's usually about managing the autonomic nervous system and where they're at the time. And then we talked about the management strategies, which I've recapped earlier. So the blood volume, the compression, the exercise in supported positions, then progressing, as well as the, making sure the joints are taken care of and supported. And then we talked about the medications and the multidisciplinary team, the MDT. Yeah, it's been great. Has there been anything that we've missed that you wanted to say?
No. Well, there's always a lot for me to say around this space. I think that what you've summarized is exactly for people that are listening for the first time to POTS, there's a lot to absorb. And I think, we've really covered what is important for the practitioner who's really trying to understand this condition. If they want to know more, they know where to come to. We're always happy to give more information. Yeah,
and that's the potsfoundation.org. So potsfoundation.org.au. And you have that. I think you've got an event for GPs that are coming up.
Yes, so in September, we're just defining that date. But what I should really say, or I'll be in big trouble, is that we run a conference every second year, and we have a practitioner day. So that's predominantly clinician focused and research focused, and then we have a community day where we try and encourage people with a range of conditions to come to, so people with POTS, but obviously with other conditions like migraine, fibromyalgia, and so on, to come. So that's going to be the 4th and 5th of June in 2026 in Adelaide. And we've got, I can't say who, but we've got an absolutely fantastic international speaker coming for the scientific day, possibly two. Actually, we asked two, thinking that neither would come, and both are looking like they're going to come. So you get a lot of information there. We will be covering not just POTS, but the range of conditions that affect these people. So things like fibromyalgia, Sjogren's disease, ME/CFS, long COVID, and we'll delve into the pelvic pain space as well.
Amazing. Yeah. Do you know if are they going to do an online option for that, Marie-Claire?
We usually do. It's for anybody who's ever run a conference, the thing that kills you about online options is that they're unbelievably expensive to facilitate. So we're unfunded. We do most of what we do out of our community's generous resources. We get zero money from the government, and in fact, no research money for POTS has ever come forward from the Australian government. So even all the research undertaken in Australia around POTS is funded by people who are sick with the condition and their families. So the short answer is yes, we will have some sort of online. We just don't know yet whether we'll be able to offer all of the workshops simultaneously. But we do always record them and have them available afterwards. So if you sign up for the conference, and you can't see every workshop, you will get the rest of the workshop sent to you once the video production is done.
We have a large international audience, so they're going to be interested in in this topic for sure.
Yeah. Well, I'll make sure that we send through the information as soon as it's out, and we'd love to see.
And we'll put all of Marie-Claire's details and the POTS Foundation details in all the show notes. I want to just finish up by saying a massive thank you to Marie-Claire for all your time today and sharing your knowledge and just being so open to having these conversations. I think I feel like I'm learning every time I speak to you, every time you do a presentation. And I feel like it's one of those topics that actually you kind of need to hear multiple times before it really sort of sinks in. Because the autonomic nervous system is obviously it's so complex, and it's working so hard to do all these different functions to keep us upright and mobile and eating well and doing all the things that we need to do. So it's such a fascinating area, but it's incredibly complex, and I feel like we've just got the tip of the iceberg today. But a huge thank you for your time today, and maybe we'll get you on again next year to give us an update if that's okay.
Oh, I'd love to. And thank you for taking the time. It's great to get this information out there, especially into the women's health domain. So thank you for the opportunity.
No, it's fantastic.
Our pleasure.
And those of you who know me, and you may not know me, Marie-Claire, but I was very restrained with my questions today, but I've got a million of them. So I'm looking forward to having you back. Maybe let's get you, we'll get you back before June so that we can definitely promote that conference as well.
Yeah, that'd be great.
Awesome.
That's a good
All right.
idea.
Thanks very much. Well, that's it for this episode. Be sure to hit like if you enjoyed the episode and leave any comments or questions below. We'd really like to hear from you.
If you haven't already hit subscribe, please do so now so that you can be kept notified when we release our next episode.
Otherwise, thank you for listening, and we look forward to having you back with us for another episode of the Women's Health Podcast.